So cystic fibrosis is an autosomal recessive disease. It is due to mutation in CFTR gene, that is cystic fibrosis transmembrane conductance regulator gene. This mutation leads to increased viscosity and thickness of body secretion, plus high chloride in skin. Now, due to defect in this gene, the CFTR genes, the transport of chloride ion is affected. Chloride ion and bicarbonate ion, it is affected. So whenever there is a defect in this gene, what will happen? Two things will happen. Excessive chloride will be secreted in the sweat, and thickness of body secretions such as pancreas and mucus, pancreatic juices, pancreatic enzymes, their thickness will be increased. Similarly, thickness of mucus that is produced in the respiratory tract will also be increased. So two things you need to remember for cystic fibrosis is that increased viscosity and thickness of body secretions and increased secretion of chloride ion into the sweats. So what signs and symptoms a person will get with cystic fibrosis? First of all, he or she will have a salty skin. And due to thick secretions in the lungs, due to thick mucus production in the lungs, it will be really difficult to clear this mucus, which will lead to accumulation of the mucus in the bronchi, and which will lead to, because mucus is not properly cleared, it will result in colonization of bacteria in the bronchi and respiratory tract infections. So there will be a history of recurrent respiratory tract infections, and recurrent respiratory tract infection can damage the elastic tissue of the lungs or bronchi, which will lead to permanent dilatation of the bronchi, which is known as bronchiectasis. So you can say that cystic fibrosis is a cause of bronchiectasis, or long-term respiratory complication of cystic fibrosis is bronchiectasis. Now, these are the problems in the lungs due to thick mucus. Now, what will happen due to thick secretions in the pancreas? Due to thick secretion in the pancreas, pancreatic ducts will be blocked, and because pancreas releases a variety of enzymes that is required for the digestion and absorption of fats and other nutrients, and because of blockage to these enzymes, these nutrients will not be absorbed, and the person will complain of steatorrhea. What is steatorrhea? Steatorrhea is fat containing stool. How a steatorrhea will present to you? Steatorrhea will present with bulky, greasy, and offensive smell stools. And due to long-term blockage in the pancreas will be damaged, and insulin-producing cells of the pancreas will also be damaged. So the person will get type 1 diabetes mellitus. So if someone presents to you with recurrent respiratory tract infections and malabsorption diarrhea or steatorrhea, then your diagnosis will be cystic fibrosis. How will you confirm your diagnosis? The diagnosis will be confirmed initially by sweat chloride test, and then the most appropriate test would be CFTR gene testing. So adults with cystic fibrosis will present to you with the involvement of two systems. One is recurrent respiratory tract infection or bronchiectasis, along with steatorrhea. So if these two manifestations are present in an adult, then you will suspect cystic fibrosis. The initial investigation that you will order will be the sweat chloride test, and the most appropriate investigation will be CFTR gene testing. Remember that the other manifestation of cystic fibrosis is that it produces a salty skin. So in children, disease will present, patient will present to you that the parents will observe that his skin is salty when they kiss the baby. While in the neonate, how cystic fibrosis will present to you because of thick GAT secretions, the neonate will not be able to pass his first stool. So early after birth, the meconium is the first stool that is passed by a newborn might not be passed due to thickness. This is known as meconium ileus. So neonates will present with meconium ileus. Children will present with salty skin, and adults will present with recurrent respiratory tract infection and malabsorption diarrhea or steatoria. In all these cases, the initial test will be sweat chloride test, and the most appropriate would be CFTR gene testing. The person can develop diabetes, he can develop cirrhosis, respiratory failure, bronchiectasis. So these are the long-term complications of cystic fibrosis. Diagnosis, we have all discussed that when we'll go for a sweat test and when we go for a CFTR test. Now, in the UK, there is a neonatal screening test for cystic fibrosis. In UK, usually Guthrie test. What is Guthrie test? Guthrie test is usually heel prick, is also known as heel prick test. Heel prick test. In heel prick test, what is done? That a blood sample is taken from the baby's heel, and it is tested for different genetic or diseases, one of which is cystic fibrosis. So the screening test in neonates for genetic diseases, including cystic fibrosis, is Guthrie test, which is done on a 7 to 10 days old baby. While sweat chloride test, and if on screening, the screening test is positive for CF or cystic fibrosis, then we will order sweat test, and after sweat test, we will order CFTR genetic test. So you can say that the screening test for cystic fibrosis in neonates is Guthrie test or heel prick test. While the initial test to confirm the diagnosis is sweat test, and the most appropriate is genetic testing for CFTR, because it is an autosomal recessive disease, and if both the parents are carrier, then 25% of the children will be unaffected, 25% will be affected, and 50% will be carriers. Because this is an autosomal disease, so males and females will be equally affected. So the questions will not be asked about how much daughters or how much chance of a son to get affected. Other autosomal recessive conditions, they include thalassemia, sickle cell anemia, Wilson disease, congenital adrenal hyperplasia. There is no cure for cystic fibrosis. We can only provide supportive care. For example, if there is lung involvement, then antibiotics such as azithromycin can be used on long-term basis, and for thick mucus secretions, hypertonic saline and salbutamol may also be used. And if lung function continue to worsen, then lung transplantation may also be an option. And the GAT problems can be solved with pancreatic enzyme replacement because the GAT abnormality is basically due to pancreatic enzyme deficiency. So that's why pancreatic enzyme replacement can be done if the person has steatorrhea. Chest physiotherapy can also be done, and it can have long-term effect, long-term benefit. The average life expectancy is between 40 to 50 years in the developed world, and lung problems are responsible for death in 80% of the people with cystic fibrosis. For exam, you need to remember that cystic fibrosis is autosomal recessive, and if both the parents are carrier, then 50% of the children will be carrier, 25% will be disease, and 25% will be unaffected. Whenever you suspect cystic fibrosis, the initial test that you will do is sweat test. Now, another disease is polycystic kidney disease. We have chapter that and hypertension, hematuria, hypertension, and abdominal fullness, abdominal pain, kidney disease. And to confirm polycystic kidney disease, we'll do an ultrasound of the abdomen. Genetic testing is usually not done. It is because genetic testing is very complex. So for Plab 1, you will pick ultrasound of the abdomen to diagnose polycystic kidney disease. And the second point that you need to remember about polycystic kidney disease is that it is associated with berry aneurysm, and that it is an autosomal dominant condition. Because it is an autosomal dominant condition, so if one parent is affected, 50% of the children will be affected, and 25% of the grandchildren will be affected. Other autosomal dominant condition include Huntington disease, neurofibromatosis, and BRCA gene mutation. Now, another disease is Turner syndrome. Turner syndrome is that when a female has one missing X chromosome, that she has 45 pair of chromosome, while the 46th pair missing. So what will happen if one X chromosome is missing? Because one X chromosome is missing, there will be a deficiency of growth hormones and learning difficulties and low estrogen. So the female will have a short stature due to deficiency of growth hormone, short webbed neck, widely spaced nipples, ovarian failure. Turner syndrome is a cause of primary amenorrhea. We discussed it in gynecology chapter, impaired pubertal growth, and bicuspid aortic valve. So these are the some common features of Turner syndrome, and you need to focus more on these one, the one that are highlighted green, because they will help you in making a diagnosis. A 20-year-old female is short for her age and has extra skin fold on the neck. On important additional feature is ovarian failure. So a short statured female with ovarian failure, you will suspect Turner syndrome. 16-year-old female with primary amenorrhea, short stature, low set of hair, broad chest, widely spaced nipples. So all these are features of Turner syndrome. Now our next disease is Prader-Willi syndrome. Prader-Willi syndrome is basically due to deletion of some genes on the paternal chromosome number 15. It is a genetic condition in which there is deletion of some genes on paternal chromosome number 15. Some genes are deleted from paternal chromosome number 15. Prader-Willi syndrome, the manifestation of Prader-Willi syndrome during neonatal period and during childhood is different. There is a mnemonic to remember Prader-Willi syndrome. That is, Brother Willie is like an octopus. He's floppy and likes to eat a lot. So during neonatal period, it causes hypotonia due to thin upper lip and downturned mouth, short floppy baby or hypotonic baby with almond shaped eyes and difficulty to feed. Your diagnosis will be Prader-Willi syndrome because Prader-Willi is like an octopus. He's floppy. So a floppy child with almond shaped eyes, Prader-Willi syndrome. During childhood, the manifestation include excessive eating, hyperphagia, and due to excessive eating, uh, the child become obese, and there are learning difficulties, growth abnormalities, self-injurious behavior, etc. So these are the manifestation of Prader-Willi syndrome during a neonatal period and during childhood. Next topic is Duchenne muscular dystrophy. Duchenne muscular dystrophy is a proximal muscle weakness due to genetic causes. Duchenne muscular dystrophy and Baker muscular dystrophy. Both of them are genetic disorders that causes proximal muscle weakness. In rheumatology chapter, we discussed about polymyalgia rheumatica, dermatomyositis, and polymyositis as causes of proximal muscle weakness. And in neurology, we discussed myasthenia gravis, Lambert-Eaton syndrome, and myasthenia gravis, Lambert-Eaton syndrome. These were the causes of proximal muscle weakness. Now, in genetics, you need to remember Duchenne muscular dystrophy and Baker muscular dystrophy as a cause of proximal muscle weakness. So, whenever someone has a proximal muscle weakness, he will have an inability to stand up from a sitting position. So, let's discuss some features of Duchenne muscular dystrophy. For Plab 1, criteria for DMD include 4 to 8-year-old male who start to walk late. So a male in the age range of 4 to 8 years who start to walk late, normally the child start walking at 12 months of age, but in case of DMD, the child will start to walk late, that is after 18 months. Gower signs will be positive. What is Gower sign? The boy will use his hands to push on his legs to stand. Let me show you a diagram. You can see that the boy is pushing his own hands to stand up because he has a difficulty in standing up. And due to weakness of the muscles of the pelvic girdle, the child will have waddling gait. So Gower sign and waddling gait and proximal muscle weakness in a male child who is 4 to 8 years old, your diagnosis you will suspect Duchenne muscular dystrophy. The initial test you will order is creatine kinase. ALT and AST are also raised, but creatine kinase is more specific. Plus minus there can be respiratory or cardiac manifestation as well. So initial test is creatine kinase. The second test is muscle biopsy. Muscle biopsy will confirm the presence of or the absence of dystrophin protein. This is a protein that is normally present in the striatum